I just realized if Len can get through 18 months, then he would be doing well. But yeah, I mean, I would say that Dr. Lamb is probably on the money here. Let me throw it open to some of the other guys to ask you some questions and discuss your situation. Guys, who'd like to talk to Harrison?
I guess I've got a question. In proton beam therapy, do they recommend that you go on ADT, on hormone treatment, while you're undergoing that, or do they don't care?
Yes, actually, the standard of treatment is to go on hormones a month before proton, and according to what they say, the androgen therapy works in synergy with the protons. A lot of guys go on right before, but the best case scenario is to go on the Casodex and the Lupron about a month before you start the proton therapy.
So it's the same as IMRT recommends the same thing with higher Gleason scores. Okay.
Yeah.
Yeah, very similar. Anybody else like to ask a question to Harrison or ask a comment?
Well, as a patient of Dr. Turner's, I mean, I agree with you. I think you're in really good hands as a prostate oncology specialist. And I trust them in terms of keeping an eye on your treatments and let them go for more aggressive treatment and so forth. They don't treat you like a number there and ignore you. They care about you. Dr. Turner called me as soon as he saw my PSA going up a little bit and said, "Hey, time for radiation." So, I mean, even before I had a chance to look at my own results. So, I think you're in good hands there. And the PSA, yes, it's climbing a little bit, but I bet you Dr. Lamb is watching carefully.
Yes, I agree with you.
I see Len joined us. Len, can you hear us? Can you hear us, Len? I see him there, but I don't know if he. Are you there, Len? Well, if you can hear us, we have a gentleman who's got a very similar situation to you, so I was hoping that you would be on the line, but it sounds like we may not be able to hear you. I see your microphone is on, but we're not hearing you, so if you can...
He can hear us, but we can't hear him.
Yes, okay. Well, that's frustrating, because I would love for you and Harrison to talk, but maybe we'll do that later in the call if we can get to hear you. But you're not muted according to the software. You're not muted. Okay. Well,
Rick.
Yes.
Harrison. Just you know, for my 2 cents, I'm pretty much in the same, or I wasn't pretty much in the same situation in terms of 4+3, and I also see or talk to Dr. Schultz, and so I finished my 18 months on hormone therapy, but I mean I also had prostatectomy and radiation treatment. And mine was in the seminal vesicles and also a margin left behind. And in addition to the 18 months, it took me 9 months for the testosterone after I stopped treatment to become measurable. But it sounds like pretty much the same routine that you're going through.
Yes.
Rick, Can you guys hear me now?
We can hear you now.
Oh, okay.
So, Len, you probably heard Harrison has a situation where he had proton beam both to the gland and to the pelvic girdle, but in separate places. He did 18 months of hormone therapy. He felt that was the right amount of hormone therapy to do. And his PSA has been creeping up from 0.003 now up to 0.7. And Dr. Lamb at prostate oncology specialists is saying to him, hang in there. And so maybe you want to just give him a quick update on your situation and the advice that you're getting.
Okay, I think I lost you there for a second. Did you want me to give him a quick wrap up of what I've gone through?
Yeah, I mean, yes, give him a quick wrap up and compare his situation to your situation.
All right, so I Gleason 9, diagnosed June 2014, put on Degarelix ADT, and then just this past September, I finished 48 sessions of IMRT. The PSA was down to 0.1 as of last month. And now, so the dilemma is, do I continue ADT or go on drug holiday as my medical oncologist at Sloan Kettering is recommending?
And you've done in this second bout, you've done 13 months continuous ADT, correct?
That's right. And then I got a second opinion from Dr. O.H. at Mount Sinai, who suggested well, Rick and I were talking about this earlier today. He suggested I stay on ADT an additional 4 to 5 months, make it the full 18 months. But he wanted to add enzalutamide or abiraterone to the Degarelix, even though I'm not hormone resistant yet. He just wanted to, go for it, I guess, drive the PSA down to 0, if possible, before he agreed that I should go on drug holiday. Was that what you were looking for, Rick? Or is...
Yeah. I mean, I just want to I just want to give Harrison a somewhat similar situation, not identical, but somewhat similar, just for the sake of comparison.
Right.
I guess there's a lot of physicians now that are urging patients to take the second generation of ADT blockers earlier in their treatment, and not to wait till things get out of control before you start them. So there's probably some wisdom there, but there's also some cost too to deal with.
Yeah, I mean that's sort of what I was saying to Len, and I think the costs are the financial costs, obviously, because it's expensive, and but the other issue is, one wonders, I don't know whether starting enzalutamide and stopping it is going to affect how much time you would get out of it later on if you went back on it, and because if you're going to go on a drug holiday and you're going to start enzalutamide, you're clearly going to come off of it sometime soon. And I just don't think they've done the studies to determine how effective the enzalutamide can be over just over a short term. Len, what's your thoughts?
Well, I think you just hit the nail on the head. There's really no data. And I think all the oncologists, I've been to 3 now to get opinions on this. Drug holiday or no drug holiday, continue ADT, first line, second line, and they all say the same thing. There's really no data, but they all just seem to have their own gut feeling about what the proper thing to do is. So who knows who's right?
I would say part of this, Steve, Len, part of it hinges on, A, how you'll feel on the enzalutamide. My own personal experience is I think I feel fine after about 3 months of enzalutamide. I don't have any noticeable side effects. And the other one is cost. Enzalutamide is about $11,000 a month, so there is some cost considerations as well.
Right. I have Medicare primary and Aetna secondary,
Yeah.
and before I agree to do this, I would definitely make sure that between Medicare and Aetna that it's well covered.
Yeah, definitely.
And for what it's,
I wouldn't want to be paying a lot out of pocket for something that there's been no clinical trials and it's kind of flying by the seat of your pants, basically.
Right.
For what it's worth, this is Don Price again. Schultz suggested, and so when I started Firmagon, both Schultz and my local medical oncologist both put me on Zytiga at the same time, even though it was not castration resistant or metastasized. And knock on wood, and so that was for the whole 18 months, and the insurance picked it up.
Oh, wow.
Yeah, people use Kazidix all the time because it's so cheap, but when you think about it, using abiraterone or enzalutamide makes a lot of sense. It's just really the cost. Because Kazidix is dirt cheap and people throw it in all the time.
So, Don, when you say they picked it up, you didn't have a large copay with the Zytiga?
No, and I don't remember what it was, but it was not very much. And you, Rick, have talked about before the danger associated with how long it will remain active if you start it too early. But in my case, both of them independently, when I asked that question they both said that the idea was to try for cure. So my PSA was so low that their hope was that the combination of the radiation plus the Firmagon plus the Zytiga might actually get everything, and I think that's why they opted for it.
Yeah, I mean, I think that you see, this is another discussion that Len and I were having. The concept of, to use Snuffy's terminology, whether you can get a permanent and durable remission, which some people might call cure. And what I said to Len was, well, is this what Dr. O is driving for? Does he think that if he adds this, he'll be able to get this permanent and durable remission? Or is this just a technique to get you quicker to a point where you're on intermittent therapy? I mean, somebody like yourself, Don, or like myself, all of our treatment was up front. So you had your surgery, you immediately saw that you needed some adjuvant radiation. I won't even call it salvage because they saw it right away, they jumped in, you knew you needed the hormone therapy like I did, and they banged in some Zytiga on top of it, and what came out of it was a durable and somewhat permanent, hopefully permanent remission, which is similar to what I got. I had all kinds of different radiation therapy and 27 months of hormone therapy, and it seems to have worked, and I've driven it down. Now, you have to compare that, and that in a way is the sort of situation that Harrison's in right now, because all of his treatment is still almost in that upfront, although it's 3 years, it's all initial. The disease is only now just starting to come back. You have to compare that to other people where they're stepping in later, and so, has the disease got enough of a foothold? And Len falls somewhere in between because of the way that he's managed. Yeah.
Let me ask you a question. Whose Medicare drug coverage do you have? Is it a Plan F, or is it a better plan? And what's the company who sells it?
Who are you asking the question to, Harrison?
The gentleman that had the drug Zytiga covered by his insurance.
Okay, Don, go ahead.
TRICARE.
TRICARE.
Okay.
And who is
Okay.
TRICARE?
So TRICARE is for essentially retired military.
Okay. Okay. Okay.
But I have this feeling that that the local oncologist, kind of fudged things when he requested it. So I don't know how I don't know,
Mm-hmm.
but he might not have been completely honest when he prescribed it, and they covered it. I don't have any reason to believe that, but they,
Mm-hmm.
I don't know. I didn't ask a lot of questions.
I don't blame you.
Thank you.
Rick, I've got a couple of questions on this one.
Yes.
Because I just went on intermittent less than a week ago, last Thursday.
Right.
My dose Casedex and just wound down the Lupron.
Mm-hmm.
So Lupron and Casedex, the understanding is this is not going to cure you. It's going to buy you time to drive down the PSA, but it's not going to eliminate the cancer. When you start going on stronger things like Xtandi, is the understanding that this can actually cause a cure, or is it just a stronger drug to buy more time, or to drive down the PSA to allow the whatever radiation you get to actually take better effect and kill the cancer?
So, so your situation is kind of like Don Price's, where you had surgery up front, you followed it after a period of time with radiation, and then you went through you went through hormone therapy for how long in total before you went off?
This time of year, last time 6 months or 7 months.
So you've never done 18 months consecutive hormone therapy?
No.
Which, as Harrison said, I think is probably, I mean, if it were me, I'd be doing at least 18 months continuously. That's what I would do. Harrison and Don Price did that. Harrison, you want to comment on that 18 months that you were talking about before?
Yeah, I think 18 months is considered by some to be the outer limit to how long you should be on it. And that other question that was raised regarding Zytiga is that curative, or is that just the same as an enhanced Casedex and Lupron? And my understanding, I'm not a physician, but my understanding is it prevents the adrenal glands from manufacturing their own androgen.
Mm-hmm.
And just as the Casedex and the Lupron suppress the androgen that comes from testosterone. So I don't know, whether the Zytiga would be curative or just buys extra time.
Don, I want to come back to you, because in your situation and talking to Dr. Schultz, they're using the C word, that 4-letter C word, which is a very interesting word that I guess Dr. Schultz's colleague, Dr. Turner, hasn't used in Peter's case. Maybe you and Peter need to sort of exchange a few words here and find out, what's going on. You're both prostate oncology guys. Go ahead.
Well, I think the idea. Go ahead.
Go ahead.
Okay, I think the idea is, I mean, you all know this, but if the cancer is contained within the prostate, and you take the prostate out, there's a reasonable chance that you will get every cancerous cell by taking out the prostate. Because in my case it was in the seminal vessels and there was a margin, just taking out the prostate, and even though you take out the seminal vessels, there's a reasonable chance that there are still cancerous cells there somewhere. So the radiation, this is my understanding, so the radiation is, if they're in the field, has a reasonable chance of killing some of those remaining cancer cells, and especially if you take hormone therapy before you start the radiation, then there's an even bigger chance that you will kill some and perhaps all of the cancer cells. And if you take, whether it's Casodex or whether it's Zytiga, anything, there's a chance that any hormone, any cell that still responds, any cancerous cell that still responds to testosterone can be killed. So the question is, and I read someplace yesterday, what is it, that 0.01 PSA is about 1 billion cancer cells. And so, of those cancer cells, how many may still respond to hormone therapy and how many won't? So, my understanding is that Schultz is saying, hey, there's a chance that we will get every cancer cell that still may be remaining through doing all these things.
Just to play the devil's advocate, Don, it's similar to antibiotics in that you are, by exposing the cancer cell to these drugs, you're selecting for those that are going to be resistant. Okay, and so really it's a case of not curing it, it's a case of you dying of something else before prostate cancer kills you, because you're not going to kill every cancer cell, only your immune system can really do that. And all of us develop cancer every day, as you know, of various sorts, and our immune system is able to combat that. In the case of prostate cancer, it's a very clever cancer, so to speak, in that it mutates very rapidly. So the other concern, in addition to cost and side effects, is are you exposing yourself to something that's going to cause bad actors to be selected for, and in the future those bad actors are going to come back to bite you.
My personal feeling is that if you can have an undetectable PSA for 5 years, you're probably cured. But I only had one person that was able to meet that criteria. If you have any detectable PSA, you have prostate cancer, you'll probably have prostate cancer for the rest of your life. I treat it as a chronic disease like diabetes, as a systemic disease that you have to control, and I am resistant to using the cure word in any case where a patient has not been undetectable for less than 5 years.
And when does Dr. Lamb suggest that you might want to intervene? Has he given you a PSA where at which point he thinks that you might need to do something?
I think at 0.1, he will put me back on ADT. If it gets above 0.1, then we go to Fabio Almeida in Phoenix and have the carbon acetate, see where it is, and then get touched up for it with protons if possible. So I need to develop a timetable with him on January 6th to see develop an operational plan for what happens if things go south. So
right now you're at 0.07, is that right?
Yes.
Okay.
That's correct.
Now, Rick?
Yes.
My situation is very similar to Don's. I also had cerebral vesicle invasion. I was a Gleason 9. I am a Gleason 9. The fact that, the fact that we're on intermittent, I guess, defines the fact that we're going to have this the rest of our life. I don't think of it in terms of cure. I'm curious to see how long I can stay off of. This is my first time off of this Lupron and Casodex, and I want to see how long I can stay. But I guess I'd call it like advanced surveillance. As long as we keep an eye on this, is there any problem with going back on Lupron or going to Zytiga or Xtandi later on? If the number's low, as long as we keep watching it.
Len, what you're listening very quietly and probably quite attentively. How do you think that this all of this discussion affects your decision making?
Well, it makes me more inclined to follow the advice that you gave me when we spoke earlier, that I should probably stick with the hormone therapy for another 5 months, reach that 18-month mark. Why? Because there's data on 18 months. You know, Dr. O was telling me oncologists used to suggest 30 months, but then they ran a clinical trial. And 30 months versus 18 months hormone therapy post radiation, and there was a very slight improvement in the 30-month group, like I think he said 5% progression-free or some other parameter like that. And you know, is it worth it? No, it wouldn't be worth it to me to hang in there
Right.
from 18 to 30 for an extra 5%. But you know, everybody has to make up their own mind on that. But regarding something Harrison said about cure, I'll only speak for Gleason 9s like myself. I would never use that word for myself, and I'm not even sure at any Gleason they use the word cure, because what they prefer, I know at Sloan Kettering, what they prefer to use is NED, no evidence of disease. I know a guy, when I was getting my radiation, there was another guy there who was getting radiation. He told me he had a prostatectomy 14 years earlier, and he had an undetected PSA until this year, and then it started going up, and so he had to get radiation. 14 years, that's incredible. And yet, obviously, he still had something there.
Mm-hmm. Yeah, I mean, I think that is, that happens. I mean, the disease can come back after 10 years. It's why I don't use a cure word. I mean, my PSA now has been less than 0.1 for 3 years, I think now, or 4 years. But I don't use a cure word, because I think that if you have high Gleason disease, it can come back. At the same time, if you have low Gleason disease, I think a cure word, the cure word is probably a feasible word to use. So yeah, I would say that that's why I kind of like Snuffy's permanent durable remission. It's a long way of saying like a temporary cure, I suppose. I don't know.
Just to add something to that, Rick and others, you know, I used to run the electronic medical record at Kaiser Permanente in Northern California, and in meeting with the chiefs of oncology, and this isn't specific for prostate cancer, but we decided to not code for cure of any cancer. Mm-hmm. It was long-term, no evidence of disease. Mm-hmm. After X number of years at the discretion of the oncologist. But the term cure probably doesn't really apply to cancer, as it doesn't apply to diabetes nor hypertension.
Right. The other thing I was just going to say was that, and some of you have heard this story before, but I was, my main doctor was Mac Roach, who at the time was the chief of radiation oncology at UCSF, and he's published many places and known across the world. And I had about halfway through I'd done well over a year, and I was probably coming up on 18 months. And there was a study published at the time, some of you have seen it, which was, is 12 months better than 36 months? And they really didn't find a significant difference between 12 months and 36 months. And so I wrote to Mac, and I said, well, what do you think, Mac? Should I do longer? Should I do less? Should I go 36 months? And he wrote back to me and he said, you know, we just don't know, because it looks like 12 is as good as 36, or I think I misquoted. I think 12 was a little inferior to 36, but 18 was no different from 36, whatever it was. The head-to-head studies of the time frame are just not that clear. And as Harrison said right at the beginning, and I agree with you, it just seems now like 18 months seems a good period of time, the right period of time to stay on. Less than 18 months doesn't work. I mean, I've just seen too many guys who get off hormone therapy too quickly when they're on it up front, and their disease comes back. So anyway, that's so it's just
Hey, Rick.
yes.
Yeah, this is Bill Franklin. I just posted a link that I found completely by chance. I Googled something completely different.
Yep.
It is an old study from 2000, but it shows something that's applicable to what we're talking about here.
Okay.
The recurrence after radical prostatectomy, what kind of time frame it was in? Was it greater than or less than 2 years? The doubling time of your PSA, greater than or less than 10 months, and what was the third one? I can't remember. I'm not looking at the page right now. I'm looking at GoToMeeting. But then it has a little chart in the middle of the article about your chances of having metastatic recurrence and probability at certain time frames. Not that I'm saying this is something everybody should be worried about, or I'm trying to scare anybody. In my case, mine came back immediately after surgery. My doubling time was a month, and so my percentages are on the low side, and low being not good. But I don't know. I thought you discussed something similar to this. It's the article from Johns Hopkins.
Right. I see. I've pulled the article up. I can't read it right now. Bill, so how long have you are on you're on Lupron and Casodex, right?
Yeah, but I've only been on it for a year.
Okay.
And my doctor also is saying that with the radical prostatectomy and radiation treatment, which they started me on the ADT quite a bit before the radiation.
Mm-hmm.
I wasn't ready. I was urinary. I had incontinence, and wasn't fully recovered from surgery. So they waited a little bit before the radiation treatment. So he's saying 18 months because of some of the same studies that you read and the things we discussed before.
Mm-hmm.
So 18 is kind of like in the middle of all these studies, and there's really no head-to-head comparisons of them. So a lot of the urologists are like picking that middle number.
Mm-hmm. Mm-hmm.
So not because it's a cutoff point where the disease might become castrate resistant, but in our case, or my case, I should say, but because treat you with ADT earlier, and while on radiation, and while you go through radiation, and then hopefully it scavenges the rest of the cells.
Yeah, I think if I remember, I think, and I correct myself from earlier. I think that the study that they're basing it on was one that said 18 months is no different from 36 months, and that came out well after I was done. But there was a study that came out during my treatment that suggested 36 months was an alternative. I think it was 6 months versus 36 months. That's what it was. And 36 months was better than 6 months. And Max said to me, well, we don't know if 36 months is better than 28 months, is better than 12 months. We just don't know. But that 18 versus 36 months was the key study. Guys, for those of you who are on the telephone, and if you have a pencil handy or a pen, the article that Bill just posted for us that we can see is from Johns Hopkins, and it's called "What Happens if PSA Comes Back After Surgery." It's in their Update magazine, or Update Prostate Cancer magazine, volume 5, winter of 2000. So I'm sure you can track it down later on the internet. I just wanted to provide you with that information. Anyway, look, this has been a great conversation about, how long what do you do when your PSA starts to rise? For all of those of you who are sort of recurrent, You may not have advanced disease yet, but you are recurrent, and you're trying to figure out what to do next and how long to stay. And it's not a topic that we talk about often enough here, which is why I thought we should let it go. And as you can hear, it's involved 5 or 6 of the men who are on the call right now. So it's clearly a topic of interest, and we can always come back to it. But for the time being, I think we're going to move on and just do a roll call again, see who's here. But I thank you all for participating in it, and some of it will be available afterwards. I hate to say, even though Jake reminded me, but I forgot to switch on the recording right away, so you may miss the beginning. So let me just run down who I know who's on the call, because there are a couple of people that have joined and I don't have their names. Peter Kafka, Steve Bornstein, Harrison Miller, Jim Harrington, Jake Hannum, Eric Bookbinder, Don Price, Paul Frieda, Tom Van Zandt, Bill Whittemore, Bill Franklin, Len Sierra. Is there anybody else who's on the call? Okay.
Tom Guffrey.
Tom Guffrey. Hello, Tom Guffrey. How are you?
Guys. All right.
Anyone else? Tom, just say something for me again so I can see what number you're on.
You got it. Number 7.
Number 7. Okay. So okay. Peter's going to put it in.
Okay.
Okay.
I think number 5 is muted, maybe.
No, number 5 is live, but it may be somebody that doesn't want to identify, so that's fine. So just we'll leave it, let them listen. So let me just run down the list and see who would like to talk about something tonight. Peter, anything else for you?
No, not right now.
Okay. Steve, how about yourself?
Well, if anybody has been on Provenge, Sipulusal, I'd like to hear their words of wisdom. Okay. I'm about to start on it.
Okay. Harrison, we spent some time with you, so I'll jump over you. Jim Harrington, anyone else? Anything for you?
Hi, Rick. Rick, it's Jim Harrington.
Yes, good.
Yeah, I'd like to ask one question.
Okay, great. Jake, how about you?
No, I don't have anything, Rick.
Okay. Eric Bookbinder, anything for you today?
Yeah, I've got a couple of questions.
Okay. Don, anything more? Anything else? No. Okay. Paul Frieda, if we can hear you, do you have anything?
Yeah, can you hear me?
Yes, we can. Anything for you?
Okay, yeah, I'm on the phone. I'm on the phone tonight. My computer, something's wrong with my computer.
Okay.
Yeah, I'm curious about what people are paying for their Xtandi and abiraterone with their insurance. I found out that it's going to cost me a lot more with the Humana drug plan that I have, and I was just wondering what other people are paying.
Okay, so we'll come into that. Tom Van Zandt, anything for you?
No, I was calling number 5.
Yeah, I saw that. Sorry, anything for you, Tom?
No, I was cured.
Oh, look. You demand. Okay. Listen, next week when we come. Next week when we
can only see the top of your head.
Yeah. Well, it's.
What are you doing down there, Tom?
That's right. But Tom, what we'd like you to do is we'd like you to put cured across your forehead for the next session, if you would.
I think he shrunk.
Yeah. Bill Whittemore, I don't know if he's still with us. Are you still with us, Bill? No, I think I saw him jump off. Bill Franklin, anything for you?
Yeah, I have a question, and
Okay.
and also just wanted to know what branch of service Don was in.
Oh,
Navy.
in the
Navy?
Navy.
All right.
Nuclear submarines.
Oh,
Excellent. Retired Air Force. But yeah, Rick, I do have a question.
okay, fine, all right.
I wonder what effect that had here.
Len, anything else for you?
No, thank you, sir.
Okay, and Tom Guthrie, how about you?
I would be interested in knowing how people made their initial choices for treatment.
Okay, so let's start progressing down the list. Peter, did you say you did or you didn't have something?
No, I'm going to skip me tonight.
Okay, so let's start with you, Steve. And Steve's question is, who's done Provenge on the call and what words of advice? And the one thing I would say is that there have been a couple of threads recently on either Health Unlocked or what we now call Health Locked Out, since they don't seem to like us very much and they're restricting us on that forum. And there's also on Inspire. So the first thing I would suggest is go to Health Unlocked and Inspire and read. There's some good evidence and good tips and suggestions. The one thing that I can say to you is that it's really good to stay hydrated. The only person that I know that had really significant issues on Provenge, and I think even had to be hospitalized after one session, figured out by the third session that he needed to be better hydrated. They stopped and gave him a saline drip halfway through the Provenge, and then they put him on the balance. This is when they were reinfusing it, and he was just fine. So there is an issue about being properly hydrated. I haven't done it, so I can't say more. Jim Harrington has, and I don't know who else has, but there may be others. So Jim, start with you.
Yeah, yes, I'm here, Rick. Yes, I had it about maybe 6 months ago. The old, let's try it anyway because it extends our life, and everything that extends our life, let's do it. I had the first two Provenge were fine. The third one, they do it, you wait, now I'm trying to remember what, it's every couple weeks that you do it, and then they take your plasma out, and then within 48 hours they put it back into you after it's been treated. The last one, I had a little bit of you get a little bit of a flu-type symptom, but it didn't last long at all. There really isn't much to it. Where the plasma goes is down to Atlanta, I believe. I mean, actually, the company Dedrion was here in New Jersey. I don't know what happened to him just at the moment. Initially, of course, it was a great stock buy, a little incidental, but that's what they do. They take it, they treat it for you, they say, and then they put it back in your body. And to take the plasma out takes a while. You have to sit very still, and the needle is quite long to take it out in one arm, put it back in the other arm. And that's really all there is to it. I just had a small flu-like symptoms after the last one. Otherwise, nothing at all. If you do have Provenge, I think the cost is still $93,000, something like that. So obviously, I'm trying to pay for that. I didn't. They have Provenge nurses. I mean, I call them that because they're people who roam around. I think there's something like 10 in the area in the Northeast that go around, and you go to, well, I went to a blood bank where it was done, where blood was being given, but they work with the program. They have this equipment, this special equipment to take the plasma out, put it back in, and I did it, and no, I highly recommend it. Whether anything happens, and if anything happens, I don't know, but I do know, we all know that it can extend your life, and I figure, let's do it. So other than the fact it's still quite expensive, I still think it's about $93,000, might as well. So Jim, I mean, there's really very little downside to it. Yes, I agree with Rick, stay hydrated. Actually, you can get a little cramping, but they give you some calcium pills while you're doing it if you start to get a cramp in your leg. Really, it's all very minor.
So Jim, the plasmapheresis part, they take the blood at the
plasma out, basically. Yeah, it comes out in a bag, and you can see it. It's kind of a milky substance. Then when you get it back, it's clear.
They did it at a blood bank, not at a hospital?
Well, they did in New Jersey. I'm in central New Jersey, and it was done in New Brunswick, and that did seem odd. What they do is they take it out in a blood bank. That's because they need a special machine, and that's where they were. There's actually two machines that take it out of you and put it back in you. So The other, when they put the infusion, when they put it back in you, that was done at the Cancer Institute here in New Jersey, and that's the same place you do all the chemo and so forth. So you're sitting amongst all your friends, and it takes an hour or so to put it back in.
How long does it take to do the plasmapheresis?
I should know that. It's a little more than 2 hours. And what they do is you can see it building up the plasma in the bag. And the only problem I had is when they take it out, it's a pretty good-sized needle they shove into your arm. It's not so much the needle. It's that you can't bend your arm. I mean, you cannot bend that arm. Boy, they are on top of you because you could. It's right in the middle of your arm, and you bend it and you'd be in bad shape. But it's a couple of hours. You got to just sit there. And I thought, well, I can read books, I can watch an iPad or movies. Baloney. I couldn't really do that because you can't. You got to keep one arm really stiff. These are just small things. I suggest you do it, and I wish you the best of luck.
Thanks, Jim. That's really helpful. Thanks.
It's really a very simple. As immunotherapies go, it's the only approved one that I'm aware of at the moment, and my doctor said, might as well go ahead and do it.
Yeah.
That's all I have to say, Rick.
What's the guideline and when you should do it?
I've done a lot of work on it, and it's most effective with a PSA, the tumor burden, so to speak, as measured by the PSA, less than 22. So you want to...
Yeah, mine was well less than 22. It was 3 or 4, something like that.
Right. Mine is actually 15 right now, so I think there is a window where I think...
I agree with you. I think you should do it early as opposed to later.
Yeah.
Rick, can I comment? I haven't Provenge, but Rick referred to a thread on Health Unlocked, and there were a couple of guys there who said that they had a port inserted, and they seemed to think that made the whole process a lot easier, Steve. So I guess, there might be some increased risk for infection with a port, but I think it would make your life a lot easier if you're okay with the idea of the port.
Thanks, Len. I'm not that hot on a port. Would go into a pretty major blood vessel, probably the subclavian up here. I'm not having some experience with those. There is, especially if you're talking 5-6 weeks until this process is over. I probably would not go for a port.
Okay.
So just a couple of things that I wanted to comment on. One is that most of the guys that I've known have used the Red Cross for their blood to be drawn. A Kaiser may be different, but if you're not at a HMO like Kaiser, then they usually send you to the Red Cross. The other thing I wanted to talk about was this issue of whether you can use your arms or you can't use your arms. I mean, the guys that I know that have gone have been able to watch movies, and they have been able to read, probably with one arm, and that it seems like in some places they immobilize both your arms, and some they don't. So there's some flexibility there. So, if you don't mind, Steve, we're going to move on. Is that okay? Anything else you want to do? Are you good?
Fine, thank you.
Okay. So, Jim Harrington, you're up.
Oh, okay, thanks, Rick. I just have one question, very simple. Maybe the doctors on the call, Dr. Steve, or just you can answer this. What's the interpretation of the alkaline phosphatase in your blood? Mine's higher, out of range now.
Go ahead, Steve. Yeah, I know you. This is one.
AlkPhos is just briefly, just to summarize. AlkPhos comes from 2 organs. It's either from liver or from bone, and in our case, of course, we're much more concerned about the bone component of AlkPhos, alkaline phosphatase. It goes up. It means there's some sort of osteoclastic, meaning clastic is bone breaking down, blastic is bone being built. So the term osteoclastic means there's a breakdown of bone, in our case related to probably infiltration by metastatic cancer. Osteoblastic is usually a good thing, where it means bone is being put down. And so your alk phos is high. Normal alk phos is in the range of about 115, give or take. How high is your alk phos?
150 the last time.
150?
Yes.
Yeah, that's pretty good. I mean, that's pretty minimal, but it does suggest that you have active bony metastases that are causing.
I do. I mean, I have bone mets all up and down my spine and so forth.
Yeah.
But
interestingly, if you go on radium, that's what they follow. Radium 223 or Eagle.
Oh, I see. Yeah.
They follow the alk phos, not the PSA.
Oh. So it's generally a bad sign if it just keeps going up, right?
It's generally a bad sign if it's going up. 150 is not terribly bad. It's almost, people, my level was 2,000 at one time. So it can be a lot of bone metastasis.
I see.
Mine is down to about 150 right now, too.
So as a result of what?
Oh, about everything in the world.
Okay.
I've thrown everything at it that you could possibly throw at it. But I took, I just finished 3 courses of radium, and I'm choosing to take a break for a while because it's causes me a lot of side effects. I probably will finish the radium in the next 6 months.
You're talking about Xofigo, right?
Xofigo, yes, exactly, radium 223. But that's actually, the alk phos is a very sensitive measure of how the Xofigo is working. So a 150 is certainly not bad. It doesn't suggest a lot of active disease.
Okay. Well, thank you very much, Steve. Appreciate that.
And Steve did chemo as well, but he didn't have any initial treatment, and he didn't have radiation or surgery initially, but he did have radiation subsequently after his chemo to the gland, which is sort of a debulking, and it's obviously something that's not that normal. But so that's sort of a very quick summary of the and Steve's on enzalutamide right now, along with
yeah, I'm on Zytiga. It seems to be doing something. So my lymph nodes are going down, but thank you very much. I appreciate it. I just wanted an interpretation because I see it's going up a bit.
There you go.
I'd like to ask a question.
Go ahead, Jake.
This is for Dr. Steve. Can your alkaline phosphatase be too low? You said 1 is normal.
It never will reach. It's never 0. It'll be between, I think, 15 and about 110, 115 is considered a normal range.
Okay.
But it'll never be 0. There's always some bony activity in everybody going on, whether it's because of bone replacement or injury. If you fracture your arm, for example, your alk phos will go up, right, as the bone is healing and repairing itself. So alk phos is normal to have some in your blood.
So 60 and 70 is a good level?
That's a normal level. That's something that you would expect to have without cancer.
And if it goes up, that means something's going on.
If it goes above about 110, 115, you certainly need at least a bone scan or some type of scan looking at bony metastases, right?
Thank you.
Okay, thanks, Steve. Eric, bookbinder, you're up.
Let's see. I'm still having the problem with shortness of breath. It's getting worse and worse. I've had a heart scan, echocardiogram, stress test. I'm not finding out the results of those until Thursday, which is kind of poor timing because I'm leaving for New York on Friday early morning. So if they tell me anything is wrong, I don't know what I'm going to do about my trip. Other people have talked about having the problem, but mine gets so severe that I can't do anything. If I try and do something physical, I'm just wiped out. I can be wiped out for a day or two. So they don't know what's going on. I don't know what's going on. Just wondering if anyone else had experiences like that. I did see in one of those articles, I get these emails from, I forget who, with cancer articles, and they talk about the 10 major symptoms that go along with prostate cancer. The first one was fatigue. So I guess that's kind of what I have, but it's really it's not. My heart rate I mean, just getting up and walking around the room, my heart rate will go to 130. And, you know, it's very disturbing. Anyway, the other thing I wanted to ask about, if other people had this, is I remember Dom talked about this a lot. I'm starting to get bone pain, and just certain joints and certain bones, just it feels like, you know, somebody's driving a nail into them. And I'm just wondering if anyone else has that experience and what to do about it.
So let's just go with the shortness of breath to begin with. You were wearing a monitor for 2 or 3 weeks. Have you had
2
the
weeks.
result?
I haven't gotten the result. I've not gotten the results yet. Thursday I'll get those.
You know, I've asked before. Has anyone else experienced these shortness of breath symptoms? Does anybody have any ideas or thoughts that Eric might be able to review with his medical team?
Tom, go ahead.
I do, but mine, I know what mine is from. Mine is from COPD, from smoking. And that's not Eric's issue.
No, I never smoked in my life.
Your pulse goes up to 130 after walking around a little bit. Suggests some sort of cardiomyopathy or cardiac disease. So I think they're doing the right thing by working this up, because your pulse, you know, walking around the room shouldn't go up. I'm assuming you're not very anemic, right? Your blood counts have been okay?
Yeah, they're fine.
Yeah, so it suggests some sort of cardiomyopathy, which is certainly something you can get from chemotherapy and God only knows what, viral and so on. So, I mean, they should definitely be working that up.
Well, Eric, I'm surprised that you say you're not anemic. I would think that most people with as much treatment as you've had would have fairly low H&H. Do you know what your actual values are, hemoglobin, hematocrit?
Yeah, I get them. They put them online, and I get them. I'm at the low end of normal.
Oh,
but,
okay.
It's been normal, yeah.
And what
Yeah,
about your resting blood pressure?
I've always had low blood pressure. When I started on Zometa, both my blood pressure and my heart rate went up. So I've been trying to talk them into believing that that's what the cause is. But I did change from having the Zometa monthly to having it every 3 months. And I thought that might help, but it doesn't seem to have helped any.
So Eric, what did you change the Zometa to? I couldn't hear you. What did you go to?
I changed from monthly to every 3 months.
I mean, could they put you on just another drug like Xgeva or Boniva or any of those? I mean, they all kind of work the same, because you're right, it could be a drug side effect. It could absolutely be a drug side effect.
It started getting really bad when I was on Xgeva, and they switched me from Xgeva to Zometa to try and see if that, would make the shortness of breath go away. Instead, my blood pressure went up and my heart rate went up. And my resting heart rate now is 105.
It's really high. Resting heart rate should be in the 60s or 70s, the highest. So, I mean, there's something going on there for sure. And, you need to get the bottom of it.
That's what I'm trying to do. I keep going and getting. I mean, the echocardiogram was done 4 months ago, and they said everything was fine. So, but now they did the stress test. But
where are you?
I'll see what they. Go ahead.
Where are you doing this work, at UCSF or at Outer Bates?
It's been done through Outer Bates.
And have you?
Yeah, the people at UCSF kind of go, yeah,
That's good. A cardiologist and a pulmonologist working you up, right? This is just not a general internist, right?
No, it's pulmonologist.
And a cardiologist, right?
I'm sorry?
Cardiologist as well?
Yes, yeah. Both.
Yeah, well, you're seeing the right people. I mean, if they can't come up with it, side effect from drug can mimic anything,
Sure.
So I wouldn't give that one up, just because they say no.
I think Len might be onto something. Anemia can definitely cause both of those symptoms: shortness of breath and increased heart rate.
Maybe
Yeah,
it's
well,
not
just before I was diagnosed with prostate cancer, I mean, literally just before, they diagnosed me as being B12 deficient.
Yeah.
And I definitely had a lot of those symptoms, then, and I was definitely anemic. But, as soon as I started getting the B12 injections, the blood counts all came back in line.
Yeah, you can't call it anemia if you're not anemic. I mean, it would be, tell you the truth, it'd be great if that was it. It would likely be treated, But if you're not anemic, you're not anemic.
No.
Are you still getting the B12 injections?
I take it orally now, and they measure it every 3 months, and it's been fine.
Okay. Well, again, don't know, but like Steve says, I mean, if you're working with a pulmonologist and a cardiologist, the only other thing I would probably suggest to you, I mean, I sort of sound like a broken record on this one, but these guys see it all the time in cancer patients, is to talk to SMS and BJ and see if they have seen this and if they have any thoughts. Have you reviewed this with BJ?
BJ prescribed Ritalin for me. The cardiologist was horrified.
Okay. So, go back to BJ and say, Ritalin wasn't right, and just ask him the question, have you seen shortness of breath?
I did, and he said he was not familiar with it.
Okay. All right. So that's, we've been through that.
I think I told you last month or something that I experience it when I lift anything heavy. I've just got to sit down and rest for quite a while. But I go to the gym every day, and I don't feel it at the gym. I go on a treadmill, and I work out with weights. But if I try to lift anything heavy or exert my muscles, then I feel it. It goes back to what we were talking about when we initially opened up the conversation this afternoon. That's why I want to go on intermittent status and get off of agency, because I think it just stresses my strength so much that I just totally get out of breath and I waste it. So I'm gonna try the next difference.
Yeah, but I don't think that's not an option for Eric. I don't think, is to get off the ADT. So
anyway, I'm just trying it for myself to see if it makes
sense.
Yeah, I definitely, it's definitely true. If I pick up, it's much worse. Like if I try to go upstairs, I have some problem. But if I try to go upstairs and I'm carrying something, that wipes me out.
Right.
But, it could well be a side effect from the ADT. I mean, it is a known side effect of the ADT. Yeah. Now, what you do about it is another thing, but it could be the ADT that is the culprit for causing the comorbidity. It's just a question of how to do it. Let's just go quickly to the other issue that Eric raised, which was how to deal with bone pain. What sort of pain regimen, treatments are you taking right now?
I have Norco, PRN. Everybody tells me, well, don't worry about getting addicted because, it's much more important to deal with the problem. But I still don't really want to take it on a regular basis. I mean, they did suggest that I take it every morning, but I haven't really done that. I take it PRN, and it does make the both symptoms, much better. That the out of breath thing seems to be better when I'm on Norco, and the bone pain also. If I get the bone pain, I take it right away.
So
it seems to take about half an hour to 40 minutes to take effect. Yeah.
So what I've learned over the past couple of years is that there are usually two medications that are prescribed. One is a constant daily medication that is supposed to address the underlying pain. And then there's a second medication that's usually prescribed for intervention when you have excessive pain. So, and I forget, I'd have to go back and look which one is which. Steve probably knows. But from a standpoint of pain management, it does sound like one needs to be on some sort of underlying pain, daily pain management pill at the stage you're in. You know, the other issue, the other point, and then I'll turn it over to Steve and anybody else, is that once you start to deal with bone pain, it's probably a good time to consider Xofigo, and not to wait too long.
Well, I didn't need oil.
Yeah.
Steve?
No, I agree with what Rick is saying, Eric. I think taking the PRN narcotics is probably not the way that most people in palliative care advise it these days. They advise more taking it on a more regular basis, so you have levels. Getting addicted to it, yes, it's always possible. But you know, I think taking it so that you're comfortable, and then going and taking some other drug when you have pain beyond the sort of your chronic level is the way most palliative care docs look at it. I think along with your cardiologist and pulmonologist, somebody you probably already seeing at Alta Base or UCSF is a palliative care specialist. I think that's somebody that is really tuned into the current thinking around taking narcotics and non-narcotic analgesics. And so I would hook into a palliative. That's not hospice. You know, this doesn't mean you got 6 months or less.
He has one.
A palliative care doc is going to be very, very expert in that, and a cardiologist, pulmonologist, oncologist is not. They're going to tell you, don't take too much of the hydrocodone because you're going to get addicted, and that, you know, you have the fear of God with that. So I would see a palliative care person for sure. I mean, I think that's important.
He has one, Steve.
Well, he has one, yeah.
Yeah, he has one in BJ Miller, is a palliative care doc.
He's the guy that puts you on the Ritalin?
Yeah.
Yes.
Well, second opinion might be sometimes a good idea as well. The other thing is Xofigo, yeah, if you've not been on Xofigo, I can speak from my own experience taking 3 courses of it so far. You only get 6 lifetime courses of it, so you have to, you know, use your bullets well. And if you're getting a lot of bone pain, you know, most men, I think it's 60+%, have significant improvement in bone pain after Xofigo or during the course of Xofigo. So I would certainly consider that. Your bone marrow is good, you're not anemic, so you're a pretty good candidate, and it's pretty dramatic. I mean, I did find what I considered 10 to 12 years of chronic back pain, which is probably unrelated to cancer, definitely got better on the Xofigo, which was interesting.
To what do you attribute that, Steve?
Placebo effect, maybe? I don't know. I have no idea. I have no idea, but it clearly is better. I wake up now and I don't have back pain like I had for the last several years, 10 or 12 actually. Now I have 2 discs as well in my lumbar spine, so it's sort of like not just the cancer, but it's dramatic. I think the Xofigo does improve the bone pain.
Yeah, it's only recently that I've started getting the bone pain, so I haven't even talked to a doctor about it yet.
Yeah, I wouldn't hesitate to take it. It's I mean, you go in every 4 weeks and they give you this injection. It takes about 10 seconds, and then you basically have to watch your bone marrow, the white count, and the platelets, and the red counts, and so on. But if your marrow is in good shape, it's pretty easy, I must say. It's pretty easy.
One thing I remember Dominic used to say,
watch where you pee so your family doesn't get exposed to where you're peeing, but other than that, it's pretty easy.
Why did you stop taking after 3, Steve?
Well, I only get 6 bullets in your quiver there, so to speak, so I want to save them till I need for sure. No other good reason.
Okay. Eric, as far as the painkillers and the...
Hold on a second. Len, you wanted to get in.
Oh, well, yeah, I'm recalling what Dominic used to tell me, that when he had his very severe bone pain, he'd always say, well, I let myself get behind with the medications, meaning that he would wait too late before he took it. And Eric, since you're taking a PRN, maybe that's it would be helpful to you if you took it earlier. You know, don't let it get to a point where you're already in some pretty serious pain and then take it and expect it to work well. That's just coming from Dominic, not from my own experience.
I think that's very good advice.
Yeah.
Jake?
I'm going to go cry in the corner now because Len said pretty much exactly what I was going to say. The important thing is to stay on top of it. Don't wait until it gets bad. And you know, my doctor told I take oxycodone 2 times a day because I had lower back pain, and I was concerned about being addicted too, and she said no, you won't be addicted. The people who tend to get addicted are the ones who have temporary back pain, and then the back pain stops, but they keep on taking the pill. They're the ones that get addicted. Somebody with cancer generally do not, according to her.
It's the middle-aged housewives who are depressed that get addicted. That's who gets addicted.
Right. So don't be afraid to take it. Is my suggestion, my advice.
Okay, Eric. So you know.
Okay. Thanks, Eric.
Maybe a review with BJ on how to manage your pain meds. Maybe a second opinion. But certainly some consideration of your timing on your pain meds is in line, and discussion over Xofigo, and continued diligence with the cardiologist and the pulmonologist. And you know, it may well be that if you change your pain medication, it may make a difference on this out of breath situation too.
One other last comment, Eric. On my cell phone, I have an app. This is an Android device that can measure it's a pulse oximeter that you can download for free. And it's interesting because I don't know if they've probably done your pulse oximetry. You just put your finger on the sensor, you know, which is basically the thing where the the light comes off, and it measures your PO2. And it'd be interesting when you have a pulse of 130 when you go up a flight of stairs to measure it and see if your PO2 is low, because that would then say you've got pulmonary disease for sure. So you can do that. Just download it.
I have one. I have, you know, the little device like they use in the hospital in the doctor's office where you stick on the end of your finger. And my oxygen rarely is below 98. It's usually 99.
Probably not pulmonary disease. Probably not pulmonary disease.
No, and I've had, you know, CT scans on my chest, several of them, and you know, looking for a pulmonary embolism or any other problem. And none of that has shown anything. It's all clear.
So your PO2 would be down if it were a pulmonary embolus. That's one way you can tell. But you know, I think your idea about it being a medication side effect is, if the scans you've gotten are negative, I would push that one with your docs. Don't be afraid to keep pushing it.
All right.
Okay, we're going to move on to Paul Frieda, whose question concerns the costs and handling insurance for these more expensive drugs. Is that right, Paul?
Yes. I was kind of surprised that the plan that I chose, which was recommended by the software, looked like I had to pay $2,000 the first month for Xtandi. That seemed a little bit high. And then after that, they want $400 or $500 every month. Mm-hmm. So I'm a little concerned about that.
Now, this is Eric. I was on Xtandi for a while, and the another one of those articles I got talked about the price of enzalutamide Xtandi, and how in other countries it's 1/4 to 1/3 what it is in the U.S. Yeah. But you know, mine was, you know, on the upper end of, you know, close to $10,000 a month. I'm on Medicare.
$10,000 a month.
You know, I do have Part D insurance, and I was paying my copay was about $300 to $400 a month until I hit the hole, and then I had one dose that cost me $3,000, but the other ones were $300 to $400. I also had to fight with the insurance company. They refused to pay for Xtandi. They wanted me to go on Zytiga or something else first, and it went to review, and their Medicare review people told them they had to pay for it. So, but then I stopped that when I'm on an experimental drug at UCSF. It doesn't have a name; it just has a number, and they stopped the Xtandi at that point. So I can't tell you what's going on now with it, but that was my experience for the 5 months or 4 months, 5 months, I guess, that I was on it.
Yeah, it is.
Which insurance did you have?
Oh, well, it's a Part D supplemental. I'm on Medicare. The Part D, it's something bizarre called SilverScript. That's the name of the company.
SilverScript.
If you sign your Part D, are you over 65?
Yes, I am.
I am, yeah.
Yeah.
So if you assign your Part D benefits over to any particular carrier, it's $11,000 a month. That's what it is, period, in the United States. And you know, generally they're not going to be able to prescribe it unless you're castrate resistant. That's one thing. In other words, you've failed ADT and Kazodix and so on. But if you're Medicare, it's covered. It's a covered drug. Part D Medicare covers it. It all depends on your copays, and like Eric's talking about, if you have a donut hole, you can hit the donut hole also. But you should have a ceiling where you can't pay more than a certain amount in a year. I'm on it. I've been on it 3 years. It cost me $5 a month. So I'm lucky because I have pretty good coverage. But I look at this costs Kaiser Permanente $11,000 and it costs me $5,000 or $5, and it's like, that's a pretty good deal, you know.
What insurance do you have?
Kaiser Permanente.
Kaiser.
Oh, Kaiser, yeah.
Mm-hmm. And
Eric,
well, I'm
I just got a
concerned
quick question. So if you only have Medicare, I thought Medicare only paid 80% of prescription drugs, even under Part D. So how is it that you were only having to pay $300 unless you had a secondary insurer?
Yeah, I do. The secondary insurer is called SilverScript.
Right.
And
so
Medicare
I have
pays.
SilverScript too, but I thought that was kind of just what they call the Medicare. It's Medicare SilverScript or something.
No, you have to have some kind of supplemental in addition to just Medicare, or you're going to get hit hard.
Yeah.
Okay.
So that's Part D, and I've never really fully understood exactly. I mean, Part D is supposed to cover you pay for Part D, so it covers everything that the Medicare doesn't cover. But with some drugs, there are even expenses with that. So Eric, you're paying the supplement for SilverScript, but you're still having to pay some cost, or you were having to pay some cost for the enzalutamide, correct?
That's correct.
Okay, now Don Price, who, if we can pull him away from his kitchen for just a second, seems to have with the military insurance, seem to do the trick for you with Zytiga, which is a comparable price to Xtandi, right?
Right. I think I paid. I did have a copay, but I think it was like on the order of $50 or $75 a month, and that's
yeah.
That was pre, and I still am for a few more months, pre-Medicare.
That's a good deal. Navy insurance, military insurance tends to be very good.
Now, my understanding was that Zytiga is about $3,500 a month, as opposed to the Xtandi, which is, as they were saying, 10 or 11,000.
Well,
that's why the insurance company wanted me to go on that first.
I think that's confusing copays, because the drugs are similar in cost. It's a question of the copay, and the copays are somewhere around, depending on the company, $2,000 to $3,000 a month is generally the copay.
And then the issue of prednisone and the abiraterone as well. A lot of people would favor not having to take prednisone. So
right.
That's the other issue when you're talking about the two. Otherwise, I think Rick is right. They're both really expensive.
Now, I just want to come back to Don Price for a second, because Don, I do know that if you have the patience and you can get yourself set up at the VA, which is what a bunch of the guys who did military service have done around here, you can get your enzalutamide or your abiraterone for $8 a month. So,
and so, but the VA is a completely separate. I mean, I know it's confusing,
right.
but
it is completely
separate from this thing called TRICARE.
Right. But, you know, what I've known guys to do, at least the guys that I know that have done this at UCSF, is that they have all of their care taken. They take care of all of their medical treatment at UCSF, but then they go through the VA system and they work themselves all the way up the line till they get to the medical oncologist. It just so happens that at San Francisco VA that the medical oncologists are often in the same department. They're from UCSF, so they're in the same department as the UCSF physician, and they will approve something like enzalutamide or Zytiga or abiraterone, and then those drugs come through at $8 a month. But the treatment is they're not the treating physicians per se, so you don't have to get your treatment at the VA, but you do have to go through the system to get the drug. That's why I say you got to have the patients to get through the system. But I know several people that have done that. So
there are also some financial aid packages, and for example, Xtandi itself, I believe, if you have a threshold income below a certain amount, I think I read somewhere that was $64,000 that you can get copay assistance from Xtandi itself, from whoever makes it.
Well, there's an issue there. The answer is in theory yes, but what's happened is that a lot of these companies have given their subsidies, turned their subsidies over to the Patient Assistance Foundation and Zero, and then that money runs out. So you go to Patient Assistance Foundation and you ask them for assistance, and they say we don't have any money anymore. Now, Richard Foodie, who's not on the call today, is taking Xtandi, and he does get a subsidy from Patient Assistance Foundation, but that is funded by the drug manufacturers.
I also found that you know, very often you'll see these things that say, you know, they give you copay assistance, and there's an asterisk, and the asterisk, if you read it, says, unless you're on Medicare or any other government-funded program.
Right. Guys, we're going to have to move along because I want to get still to Bill Franklin and Tom Guthrie. Bill, you had beyond Don Price's service on nuclear submarines, you had another question.
Yeah, beyond the service rivalry, all that.
Okay.
Last Friday I had a colonoscopy, and while under anesthesia, apparently I have no I have no remembering. Ooh, I'm tongue-tied. I don't remember anything. So while under anesthesia, I apparently vomited. Right. They put a breathing tube in.
Right.
Continued with the procedure, and then removed the breathing tube and woke me up. When I woke up, I was coughing like crazy. They helped me clear my lungs out. I got some breathing treatments. They sent me home. And that's kind of what happened to me on Friday. But since Friday, the lungs have cleared up fine. I can breathe better, and I'm still coughing a little bit, but there's no pain or anything. I feel fine. But I seem to have had a really hard time recovering just from that procedure. So I'm wondering, has anybody else gone through a procedure where they had to be, where they were in anesthesia while on ADT or some of our treatments? And of course, we're physically not as strong as we were or capable as we were, but I just, like, by 5 o'clock every afternoon for the last few days, I'm beat. I mean, I get a good 8 hours sleep, and I feel fine when I wake up, but by 5 o'clock, it's like I crash. And this has happened since the procedure on Friday.
Well, I mean, the one thing that I do know, because it's happened to me every time I've had a general anesthetic, is it takes me several days to recover from it. It doesn't go away that quickly. Dr. Steve, I mean, what's your thoughts on the impact of general anesthesia? What did you used to tell your patients about that?
Actually, I pulled the plug on my computer and I lost everybody, and I just rebooted it, so I just heard the tail end of this. So you had a procedure under general anesthesia last week? Is that what I heard?
Yeah, on Friday.
What did you have done?
Colonoscopy.
Oh, colonoscopy. Well, I mean, usually that's just what's called anesthetic sedation. It's not a general anesthetic necessarily. Were you actually in the operating room asleep or ambulatory surgery?
I was unconscious, so I'm...
Yeah. Steve, he threw up, Bill threw up. He doesn't recollect any, doesn't recollect vomiting at all, and he's fine now from vomiting, and they had to put in a breathing tube and what have you, but he must have had fairly heavy sedation because he...
Yeah, and it doesn't really matter. They give you a drug called Versed, which is similar to Valium, and it causes amnesia, so you don't remember it. You experience it, but you don't remember it at all. You know, oftentimes, you know, you don't feel well for a week or two, like Rich says, after, you know, either heavy sedation. You know, MAC or monitored anesthesia care is similar, but it's not. The difference is when you're totally unconscious, you have to put in, you know, an endotracheal tube, a breathing tube, basically. Is your throat, was it sore when you woke up?
Oh, yeah. I mean, they said they put one in to finish the procedure, and they took it out before they woke me up.
Yeah, but the way you can tell is if your throat is sore afterwards.
Oh, well, it was sore, and I was coughing for about an hour or so.
Yeah, probably a general anesthetic. Yeah, no, the effects of the anesthesia can go on for a good week or two where you just don't feel yourself and, you know, fatigue and just not, you know, feel spacey, that kind of thing. So I wouldn't be too surprised by that.
You know, this is like my fourth one, and I never experienced like that after, you know, recovery. So, and I'm sure the effects of, you know, all my prostate treatment and ADT and everything has something to do with it. So.
Yeah, yeah. I mean, everyone reacts differently from anesthesia, but it's not unusual at all to feel spacey and weak and tired for at least a week or two.
So, Bill, I have a more important question. Is this post or pre your race? Did you do your race?
Yeah, we did our race on the 3rd of December.
Okay, and how did you do?
I finished.
Good.
In 31 minutes.
Good.
I was the 6th person to finish out of about 31 people.
Excellent. And it was 5K? It was a 5K, is that right?
It was a 5K. Not everybody ran the whole race. I mean, we had lots of people start walking and finished up walking, so that helped my placing in the race.
Okay. I need pictures, so we got to put a picture on our news and events page, man.
Yeah, I got to send some. I got some pictures of the group. I got a picture of me crossing the finish line.
Good.
I was the host of the 5K, so I wasn't really as attentive, like picture taking stuff, as I might be at some of those events. But
you know, you're lucky Don Price doesn't live near you, because he would have walked through all of you. He would have been there. He would have won that race hands down.
I don't know. We had
back in the day, not
retired
now.
Army major, so.
Back in the day, says Mr. Price. Hey, Don, it's warm there. You would have loved running there. You wouldn't have. It was nice and warm in Tampa.
And sea level, even better.
Yeah.
It was a beautiful day. It was about 72 degrees, and light wind, and it was low humidity. It was an awesome day for a 5K.
Well, send us a picture of you crossing the finish line. I want to just move on. We've got about 10 minutes left, and it may not be enough, but Tom Guthrie is wrestling with how to make a treatment decision for Gleason 9 disease, and I know that he's seen now a couple of urologists, a radiologist, and a urologist at Memorial Sloan Kettering. He's going to be seeing a Memorial Sloan Kettering trained you need a urinary medonc this week. Anybody want to talk to Tom a little bit? Tom, you say a few words and let's see if we can get any feedback for you on how to make the best decision.
I guess I was just interested in how other folks made that initial decision on which direction to go with their treatment. It just seems like everything apples and oranges in comparison, and it's hard to come up with a way to lean.
Well, we got Len, who was a Gleason 9, and he did something that, you know, probably you're not even considering, which was to go straight on to hormone therapy because there was seminal vesicle invasion. Peter Kafka, who chose surgery. Peter, you were a Gleason 8, right? Not a Gleason 9?
I'm a Gleason 9.
Oh, he was a Gleason 9. And I mean, I was a Gleason 8, but I made my decision somewhat differently. Let me throw it open. Anybody, jump in.
Tom, I wrote to Tom and described my situation. I think I was pretty much forced into surgery, and then but even going into surgery, I knew that radiation was going to follow, so I took that route.
Yeah, you had urinary complications going in, which is why you did the surgery, right?
Exactly. Yeah, nobody would. I saw radiologists. I went to Beverly Hills and saw a radiologist for the Stars who wouldn't name names, but told me I'd recognize the directors if they told me who they treated. But none of them would do radiation for me as long as I was wearing a catheter or had urinary problems.
I think this is Eric. I think, you know, it's a problem that we all, anybody I talked to went through. They say, well, you can do radiation, you can do surgery, and you say, well, which one? And they say, oh, it's your decision. And they said, well, what can I base it on? And they said, you just have to make a personal decision. And so I really didn't get any support, and I went to Stanford and I went to UCSF for second opinions, and nobody seemed to help. I think it's a good idea to know, you know, what are the complications, what are the side effects, what are the risks, and I was, you know, I'm kind of reticent to. I didn't want radiation because I had radiation as a kid when I was 3 years old and ended up getting tumors in my thyroid. So, you know, that was part of why I went with surgery. But, you know, one of the things that they didn't tell you in surgery is, you know, what they do is they remove the prostate they cut the urethra above and below the prostate, and then they reattach it to the bladder. There are various things depending on whether they think the seminal vesicles are involved and all that. But it does shorten your urethra by, you know, 1 to 2 inches, somewhere in that range, and which means that your penis is shortened by that much as well. So, you know, that's a complication that does bother, especially if you're younger. That, you know, most likely will bother you. I also felt that as far as radiation, you don't know what's going to happen with the radiation, and it can be several years before the problems go up if you've had radiation. Whereas with surgery, it's pretty much, you know, when you're done with the surgery, you know, you already have all the after effects right there. So that was another reason why I chose surgery. So that's my opinion.
Thanks, sir.
Anyone else want to chip in?
Tom, this is...
Go ahead.
Go ahead, Len.
Yeah, Tom, this is Len. I think we spoke on the phone, didn't we? You're up in the Albany area, New York?
Yes, yeah, I did talk to you, Len.
Right. And so you went down to MSK, and what did you get a consensus of opinion? What would be best for you from MSK? Did they tell you surgery or radiation, or they left it up to you?
No, I didn't get a consensus. I got varying opinions from radiologists versus the surgeon. No one really pushed for either direction, but the surgeon obviously was comfortable doing the surgery and thought it would be a good direction to go. But he never did say it was a better direction to go than the radiation. So, and the radiologist wouldn't say anything direction.
Did you say last
was
time?
your cancer confined to the prostate?
As far as we know, it is. All the scans say that it still is. The surgeon did a DRE, and for the first time said he thought he felt something. So the tumor jumped to a T2A, I think it is now.
Mm-hmm.
But they still don't know if it's broken through. They don't think so. But
Mm-hmm.
Well, I'm thinking if you're a Gleason 9, even if you have the surgery, your probability of requiring radiation down the line is probably pretty high.
The nomogram suggests better than 70%.
Yeah. So that's a consideration. If you're going to have radiation anyway, why not just do it up front?
I guess that's one of the things that I've had a hard time being able to understand is it going to be the same amount of radiation? Is it going to have the same effect as if I started with the radiation? No, but the radiologist said he wouldn't just give me external beam or just brachytherapy. He said he would give me both and hormones at the same time for 3 years. That was his plan if I chose that direction. So what you can never seem to find is, yeah, I might end up with radiation afterwards anyway, but would it be the same amount and would it cause the same side effects? I can't seem to get a straight answer on those things.
Well, I mean, to respond to that, you get more radiation if you do it up front because they radiate both the gland and the pelvic girdle. If they do it as salvage radiation, there's no gland to radiate. They may have to radiate the prostate bed, but there's not going to be anywhere near as much radiation, and they will radiate the pelvic girdle. In terms of the time that you will remain on hormone therapy, we discussed that at length at the beginning of this call, and the consensus today in most places is around 18 months.
Yeah, I heard you say that. I was surprised that they were so adamant about the 3 years concept.
Well, that may be Muller. Others would say differently, but I would say that most places will tell you 18 months. And it's, you know, and I, you know, he may have said up to 18 months, up to 3 years, but I think most places are. I mean, I don't know anybody in a long time that's done 3 years. I know people that have done 2 years, or a little more than 2 years. Well, a lot of people other than myself, but 3 years I haven't heard in a while. So I don't think you'd be on. I doubt very much that you'd be doing it for 3 years. But you could be doing it for as long as 3 years, but I doubt it would be a full 3 years. Again, that's not medical advice. That's just from what I've seen. That's my experience.
So, Rick, this is Eric. I'm unclear on what you're saying. You're saying that you would be on ADT for the 18 months, or what are we talking about?
Yes, continuous ADT in addition to the radiation. If you're doing surgery, if you're doing radiation as your initial treatment.
Is that presuming that it hasn't spread, that they don't find bone mets or anything like that?
That's probably what they would do for somebody, even if they don't find bone mets, that's what they do for somebody that has Gleason 9. So if you have a Gleason 9, I mean, you know, for example, I had a Gleason 8, There was no evidence of bone mets. There was no evidence in the seminal vesicles. There was no evidence in the lymph nodes. I did 27 months of continuous hormone therapy.
Tom, how old did you say you were?
59.
59. And I mean, one of the things to consider between surgery and radiation is your sexual activity, your relationship with your wife, your family. I mean, this has broader implications than just you, but it is your life that you're talking about, and you want to be around as long as you can. But the chances of coming down with erectile dysfunction with surgery are pretty great with a Gleason 9. So I mean, you got to be willing to accept that and not feel you made the wrong decision. And you might end up that way with radiation too. But I mean, these are discussions you need to have with your wife anyway, if you have a wife. I'm assuming you.
Yeah, I mean, have the doctors talked to you, the urologists talked to you about whether they can spare your erectile nerves or not?
Yeah, the surgeon said that he thought, I mean, I know this is a guess, but at least on paper from the biopsy, everything is on the left side of the prostate. There's nothing showing on the right side.
Mm-hmm.
And I know biopsies are not all that accurate. I did have an MRI too that didn't show anything on the right-hand side. So, so I think what he would probably do, at least until he got in there and found some other visual evidence of it, would be to cut further on the left and cut further away on the right, or vice versa, so that maybe be able to do some nerve sparing on the right-hand side.
Okay. So, I think it really comes down to what Len said, which is, and what you and I have talked about several times, which is whether you want to consider and undergo a whole other set of comorbidities associated with surgery for whatever you consider to be the benefit of surgery. I mean, one thing's for sure, if you do surgery, you know that you're going to have issues related to incontinence until you heal. Hopefully rapidly, maybe 30 days, maybe 60 or 90 days, but hopefully you'll heal rapidly. You won't have continued issues. And you're going to have some issues related to ED, where hopefully if they spare a nerve, that will come back. Whereas if you don't have surgery and you just go with the radiation, you can also have a whole bunch of side effects. Probably there's going to be some urgency, not so much incontinence, but urgency, I would say. You're going to have issues around ED, but they're going to take a lot longer to click into place. So you won't notice that immediately, but you may well have issues later on. But it's a sort of a, use it, don't lose it situation.
I also saw that there was a much higher incidence, especially with brachy and external beam. There was a much higher incidence of things like urethral stricture and TERP, I guess it's called. There were other issues that created surgery patients.
I don't know that there's a higher. I know a couple of people that have had urethral strictures, but they've had it after surgery. So because there's been scarring left, and it's happened. So I don't know that the urethral stricture issue is greater with radiation than it is with surgery. I think it's a risk in both cases. But then yes, maybe you do have to have a TERP, or you have to have something. You have to have something to clear this. You certainly may need something to clear the stricture. But I wouldn't say it's more. What I would say is that there's more likely that you're going to have issues around your bowel and your rectum, as we've talked about, with radiation. But again, if they're using the gel, they can minimize that. To me, it's a simple. For me, it was a simple decision. What do I want to undergo? Why do I want to undergo a whole lot of extra comorbidities? I already know what I'm going to have to undergo for radiation and hormone therapy. Why do I need to undergo all of the ones for surgery as well? And I was making the assumption that I would have to do radiation and hormone therapy anyway. If you think you might not need to do hormone therapy and radiation, I would have, if I had thought that, I would have gone for the surgery. But it seemed to me that, as I've said many times, I didn't want to roll the dice on a 30% chance. And, you know, if you want to roll the dice on a 30% chance and hope that you're the guy that doesn't need any follow-up treatment, then you don't, then you're a winner.
All right, well, thanks, guys. I appreciate the input.
Okay, so let me know how you do with Dr. Schaffer tomorrow.
Okay, I will.
Okay, and we're only 5 minutes over, not bad. We've come to the end of another session. We will have one more before Christmas on the 19th of December, Monday the 19th, next Monday I think that is. We've been honored with Don Price's presence throughout the whole of the show today, and his pizza is coming along nicely. Can we see the pizza for those of us? Is there anything
Well,
to show
it's
us?
not. No, there's nothing. I'm still. I got the sauce on. It's a white, kind of like a white sauce, but I still have to put all the veggies on and then put it in the oven. So,
Okay.
Had I
Right.
known, I would have started earlier. But
okay, all right. You're making my mouth water. I'm going to send you a picture of the dish I served Dr. Steve on Saturday. He was here with Renata, who moderates our caretaker call, and his wife, and I'll send you a picture of what they got. Not the pizza though. I didn't take a picture of the pizza.
excellent. Okay, that'd be fine. I'd like to know. I'd like to see it.
Okay, I'll send it to you. All right, guys. Let's see. What have we got coming up? We've got we don't have another caretaker call until the 20th. Oh, we have the exercise the exercise webinar from Inspire coming up on tomorrow. Tomorrow. It's at noon Eastern time. Noon Eastern time. I'm not saying anything more so I don't cross myself up. If you cannot make it and you want to hear it, you need to register and they will send you a link so you can hear it later. So the lady who's doing it is Carol Michaels. She did she was on a panel that I put together a couple of years back, that you can listen to that. It's linked on the Metafit site. It's linked on our site too, I think, on the ANCAN site, or you can call me. But anyway, she's the lady that's talking. They're really focused on 3 cancers: prostate, thyroid, and colorectal. Can't remember what the other one. Oh, testicular, prostate, and thyroid. So there you go. So I don't think, and our fundraising letter has gotten delayed because Rob is not doing well this week. Send him your thoughts and your vibes for better health and prayers or whatever you find best. He's got he's had another urinary tract infection and he's just feeling crummy all around, and so you know, I just took the pressure off of him and said, you know, whenever you can get to it. All right, that's it for tonight. I will say good night to you all.
Thanks, Rick. Thanks, everybody.
Thanks, Rick.
Pleasure. Good night.
Good night.